So welcome back, Thea. It's great to have you back on Climb.
Yeah, it's a pleasure to be back with you, Brad.
Yeah, it's you and I saw each other at the Pharmacy Profit Summit, and what a great event that was. And you were on in May on a
Mhm.
panel, but it was our longest session I think ever, an hour and 16 minutes, and the way we had split it up, you really didn't get much time until the end. So we probably lost a few people along the way. So it's great to have you back to talk about something that I think most pharmacists really don't know anything about and don't understand. It's something they're doing today, but they're not getting paid for. So we're talking about clinical consulting pharmacies. So let's just start with that. Let's define this. What is a clinical consulting pharmacist?
So what I've done is taking my experience in all kinds of pharmacy and kind of lumped it together and said, I can do a lot of things without dispensing anything. So let's take a look at what kind of consulting I could get into. And really what I've been able to develop over the last 3.5 years is really a program that allows me to take the conversations that I know and love from the pharmacy counter and get paid for my time. Even though I don't work in a pharmacy anymore, I remember the conversations very, very well on what you would get to talk about at the pharmacy counter. And so when I looked at, what is an independent pharmacy owner doing today? They're communicating with their patients because the patients keep coming back. They have plenty of opportunities to go different places. But the problem is that we're not getting any reimbursement for our time that we spend with the patients and the important questions and comments that come from those conversations are not getting heard. And that's really what I've taken and utilized and built a way to utilize the programs that Medicare already has set up for care management for patients and kind of converted that from a nursing driven program into something about pharmacy. Because when I saw the aptitude of what these programs could do, I realized quickly that this is all the stuff that I do in a retail pharmacy day. Like, I talk to the patient about what their blood pressure is doing when they pick up their medications. We tell them and educate them about how to do it and how to stay healthy and all of these things. And we're not getting paid for our time. And I wanted to flip the script on that because I'm a valued professional inside a health system. Why am I not a valued professional in the community setting and getting paid for my time? And that's really what I wanted to create and build into clinical services for independent pharmacy owners today.
Okay, so basically, I mean, pharmacies are doing all these things. A lot of them are doing MedSync, so you get all the prescriptions at once. They're talking to them on a regular basis. They're doing medication therapy management, but they're
Mm-hmm.
not getting paid for it.
Right.
And that's really what your goal is, to help them get paid. So let's start, this question is too broad. It's going to need to be broken down, but let's just start broadly with how do they get paid? What has to happen to make that part happen?
Right. And that's the best question to be answered directly, because that's the first question everyone asks. Well, how are you doing that? Exactly. So what I've been able to do is work with collaborating with the providers. Now, collaborating with an MD, collaborating with a cardiologist, collaborating with an endocrinologist, to really be able to augment what they're doing with their patients. So that collaboration in the state of Pennsylvania is a little bit different across the country, but here we don't really have a collaborative practice agreement that I would then be able to change things as a pharmacist. So I opted to go to a collaborative business agreement with these providers, taking the liability of the codes that I would be providing, because this is all incident to billing under Medicare. These programs are funded by Medicare Advantage plans, as well as all of the commercial plans available out there. So it is a medical insurance-based coverage for these programs. So there's not much out of cost expense to the patient at all, if any. And so when you have the conversation with a provider, most of the independent pharmacy owners already know their providers local to them. They know and have open communications with a lot of them. And so when you take this back and say, this patient is on my MedSync program, I call them monthly to make sure there's been no medication changes, and I want to check in and help help the patient be a little bit healthier. Can you help me do that? With the pharmacist going to a physician and saying that, they're like, yeah, and I'm having trouble with some of my star ratings, which is a whole nother beast for independent, medical practices or physician offices. They've got star ratings, just like pharmacy was coming out with before COVID. And that really, they have to meet certain metrics of how well they're caring for the patient proactively. Did they get these scans done? What is their blood pressure doing? Are they coming in for the, mammogram because it's October, right? And all of those things the pharmacies are already doing. They're promoting that it's, it's Pharmacist Month, yay, but also it's Breast Cancer Awareness Month too. And how many pharmacies are putting out there right now that, hey, you should get a mammogram done. Everyone should get this done. So those are gaps that the physician office has to close and get scheduled and done, but they don't even know the pharmacies are doing and suggesting that this stuff can get done. And so when we look at how siloed healthcare systems are today, healthcare in general in the United States is very siloed. And so when you look at, okay, as a pharmacist, I do all of these services under my MedSync. I offer resources to the patients. Now I'm like, why can't I get paid for all of this? And that's really what the collaboration with the provider really allows you to do under programs like chronic care management, remote patient monitoring. Those two programs marry completely into the same information you would need to do an MTM. It goes into these too. So it's like the added bonus for chronic care management versus an MTM that they already know how to do is really offering community services, which is what we do anyways. Like, oh, you're having trouble with transportation. Here, let me get the number for Uber, or let me get the active aging involved, or whatever we do to help them. And so we need to figure out a way to transition what we know how to do, and we're really great at it, to allow that information to go back to the provider. Because I don't even think the providers know that we do all of these services that we're not even doing because no one's paying us for. No one knows.
Sure. So I mean, honestly, and I'm sure you get this sounds hard. So, and as soon as, they want to know how they're going to get paid, but then when you start describing what, let's go into a little bit of detail. So what are some of your top tips? How do you go about doing this? You mentioned already that, yes, they have relationships with some of these, and I would say that's probably the starting point. But what do you say? How do you, and what kind of resistance do you meet when you're doing this, both from the pharmacy owner or pharmacist as well as the physician?
Yeah, for the pharmacy. Okay, so with the pharmacy, we'll take the pharmacy owner's perspective. They're like, I don't have time for one more thing. And I said, I understand you don't have time for one more thing, but what do you have time for to make money for? And when you start saying, okay, well, you're already calling the patient. Would it be hard for you to track your time when you call the patient to talk about, have their medications changed? How are you doing? Could you track that conversation? Yeah, your telephone shows you how long you've spent on the phone with that person. Oh, Mrs. Smith, I just talked to her for 12 minutes and 48 seconds, Can you write that down? If you could write that down, you could do chronic care management, because it's just tracking your time that you're coordinating care for the patient. You've interacted with them. So let's use another example with Mrs. Smith. Mrs. Smith comes into the pharmacy. She's not on the MedSync program, but she comes in every 2 days, 3 days, whatever, and picks up prescriptions. Every time it's a 5-minute conversation with your staff or you at the counter, because she just needs you. She needs to be heard, and you're doing it. And so when you look at the amount of time you interact with these patients each month, do you have 20 minutes? Probably. The conversations of calling Mrs. Smith on the phone, oh, well, I was just on the phone with her for 28 minutes because she told me about everything that's going wrong with her. And so that simple conversation of medication, are your medications still the same, before I package them so I don't waste time packaging them, then becomes full circle into, you're already calling the patient monthly. Why not offer, to explore that and get paid for that time? And so when I look at most pharmacy owners, they're like, well, we're doing that. And I'm like, I know, let's talk a little bit more on what this looks like. So then their next question is, well, I have these providers, but none of them want to work with me. Or I have providers, but they're all incorporated with bigger community entities of health systems. And I'm like, but you still have some independent providers that you work closer with. And the ones even in the health system, they're not doing great at these quality measures either. And so when you offer, okay, the push now is A1Cs and medication adherence and blood pressures. Those are the big push in quality from a physician standpoint or a health system standpoint or an insurance standpoint, because those are all the people that drive quality, right? The insurance company sets the standards based off of Medicare, and then they trickle down to, are you taking care of the patient? We've shown that patients that have been proactively taken care of cost the insurance companies less money and are healthier people. And so that's what they're trying to foster with these programs like chronic care management and even MTMs and comprehensive medication reviews. That's why it's important that these insurance companies are asking the pharmacists to do that work, but they won't pay us because we're not providers in their entities of under insurance. But when you look at, do I need to be a provider? No, I need to have an open conversation with their healthcare providers to say, I'm already doing these services, can I get paid for them? And that conversation looks a little bit different for most pharmacies because most pharmacists have never gone out and asked to sell their service versus selling a product. You know, we've never asked to get paid for our time before. And so it is a little bit of a trickier conversation to have, but I think that when you show the value of what you're doing to the provider, it's very simple for them to see why we're coming to them. It's almost a no-brainer. Like, I'm going to call the patient every month, which I'm already doing. I'm going to get them their medications, which I'm already doing. And I'm going to offer resources to the patient, which I'm already doing. And all I ask is that we do some kind of a share on that code so that I can get paid for my time. And they get some of the code, you get some of the code, and everyone's happier because we've built a whole circle around the patient of personalized healthcare. Patients love it, physicians love it, and the pharmacists just are like, I can do that? I'm like, yes, you can. I hope that answers your question a little bit.
No, it does. So, but I guess you do see resistance from the pharmacists because of time, but then well, how often, once, you know, in your experience, how often do the pharmacists have resistance from the doctors or from the prescribers?
I don't think that there's a lot of resistance from the prescribers because the physicians are burnt out and they're tired and they don't have staff and they don't have like the added people to be offering these services for their patients anyways. And that's where Medicare just came out last year for 2022. They increased the codes by 55% for chronic care management because no one was using them. And they know that they've just put out a report in 2022, I think it was data from 18 to 21, that they saved like $46 million because of medication adherence because pharmacists got involved. Like, that's huge.
Yeah, right.
And so I think that we have enough information to go to the providers and have the conversations because they can't handle one more thing either. And with the way the pharmacy prescriptions are, we can't afford not to go get paid for our services based on the reimbursements that we're seeing.
Well, especially when you're already doing the work.
Yes, exactly. Especially because you're doing the work.
Seems right. Now, so in just, you know, going back for just a second with the pharmacists, I don't have time for one more thing. When you were talking about, well, can you know, look at the phone and say it was 12 minutes and 48 seconds, write that down in the name. The pharmacist doesn't have to be the person that's inputting the code into the system, right? I mean, that could be
it's your team.
That could be your team, right?
Yeah, it's your team. Whether it's a community health worker, whether it's an intern, whether it's a technician, whether it's a cashier, as long as they're on your team and you're working as consistently with the provider under their general supervision, that does not have to be in the same building. It does not have to be just you doing the work. It is a full team effort here, and healthcare is really allowing us to do that under the general supervision of a provider. And so as pharmacists, that feels like, oh, well, I'm second fiddle. Well, guess what? You're not. You're bringing information. You're the medication expert when we look at what's going on with the patient. And so when we start looking at what these codes look like, if you had 100 patients with, Dr. A, and you were doing med sync on them anyways, you're getting the money for the medications because you're already med syncing them, but you're already calling those 100 patients under that doctor anyways. Well, what if I said, if you went to this doctor, got this agreement for chronic care management alone, and that's not even talking remote monitoring, which is a whole nother demon in this beast of, of services that you can offer, because then I geek out on data information overload and it's fun. But I'll come back to chronic care management, and the cost is, that 100 patients for 20 minutes of your time is upwards to $6,000 on the table, work you're already doing, and you're having trouble having a conversation about wanting to be paid. $6,000 is month over month. MTM services that pharmacists are doing are once, maybe 4 times a year, maybe, for $75. And I'm like, this is, you're doing the work already. I just need you to think about it a little different. Give me a shift.
Well, that's right. And I think that's why I asked that question the way I did, because they aren't involved in the billing process, right? They just have to track the time, and because they're already putting in the time. So this really, again, is one of those things you just go, why aren't you doing this? Now, there is obviously time to set up the relationships with the doctor. But I assume, like in your consulting business, you have, you teach how to do that, and have a collaborative practice agreements and things like that you can share.
Yes, exactly. And that's exactly why I built what I have. Over the last 3.5 years, I've learned blood, sweat, and tears, right? That's how you learn. And so I didn't have anyone going ahead of me and doing this work. I had people that had the idea of doing it, but no one was doing it. And so the blood, sweat, and tears that I've gained and gathered, and information, knowledge, I want to share that with the community, because I really feel like it's time for pharmacists to come to the table and say, I'm offering great service. You don't see it, but here, I'm going to show it to you and get paid for that. And so, yeah, I have built a platform of like a program that really teaches pharmacists, taking them from, pharmacy owners, taking them from not having any clinical services and doing what they're doing throughout their pharmacy day, add this in there and really show them, how to have the conversation with the providers, how to have the conversation with their, patients, as well as training their staff. It's not a difficult, time-sensitive thing that is going to consume a lot of their time. A lot of it is just a couple of conversations here and there, and they're able to get the information and get moving quickly. Like most of my clients that have taken up this program and done this program with me are usually seeing patients within 3 to 6 months. It's very quick. And if you have the engagement of your providers in your area, even better, shorter time yet.
I can't help but think about this. Boy, this is going to come, but maybe sound like it's coming out of the left field here. It's not a question, it's just an overall comment. But early on when I started RMS, we just turned 24. And early on, I read this book somebody recommended to me called The E-Myth Revisited. And the E-Myth was the entrepreneurial myth. And it talks about this lady in the book, and she has a pie shop because her friends told her she makes the most amazing pies. And she's selling these pies, but she's baking the pies. And she keeps baking the pies. And they go, you got to stop baking the pies. You got to teach people to bake the pies. You got to run the business and be the visionary for the business and make the business grow. And that's really what we're talking about here. Stop baking the pies. Stop filling the scripts. Stop, and when you're doing these, build your business. And I think that's really what we're talking about. Get out of your own head here and look at you're doing the work. Get paid for the work. So that just popped into my head. It was an important read for me long time ago, and it's had a huge impact. And that's why I'm doing things like this, like Climb, because I think that for me, this is fun. This is a passion. And, sharing great information, just like, this got to be a passion for you, getting out there and doing what you're doing. So this is really fun. Now, I'm going to go back on track here.
Mm-hmm.
You mentioned something, and I wrote it down really quickly, remote patient monitoring. And so I know that opens a whole new door to what we're talking about here. But let's just, a lot of people don't know what that is all about either. So let's delve into that a bit.
Sure. Yeah. So I would leave chronic care management close to what they already know how to do with an MTM. So taking chronic care management and MTMs one step further is remote patient monitoring. And what this program really allows us to do, this is a Medicare-driven program funded by Medicare and all of the other insurers, just like chronic care management. And it is basically, I send the patient with a chronic condition a device to use. That device is set up to a portal. Now, portals or platforms are web-based, everything, and they integrate with some of the software systems that pharmacists are using today. And that integration allows for when Mrs. Smith uses her blood pressure machine, that information comes right into your platform to see it. Once a month, you're talking to Mrs. Smith, a 20-minute conversation. Now, if Mrs. Smith uses that blood pressure machine 16 days out of the month, and you have a conversation with Mrs. Smith about that, so now what have I done? I've given the patient a plan. I've given them the medication. Now what does this do? This allows me to look at what they're doing and seeing how they're doing on their plan, really getting into the data of what they're doing. And so when you do that, the same collaboration that you have for chronic care management with the provider, now you can bill under remote patient monitoring as well under that provider. So what is this doing? This is giving information back to the health system or healthcare provider of all of the data days that the patient has. We're showing that Mrs. Smith is adherent to her medications because her blood pressure is controlled. Okay, so that's a quality measure that the provider gets tacked on. Is the patient adherent to their blood pressure medications? That's a star rating for the providers. So guess what? I'm inadvertently not getting any money for that star, but I'm increasing the star ratings of that provider as well. By Mrs. Smith using her blood pressure machine, I'm watching it. I'm seeing if there's limitations to the medication where she's having trouble. Maybe it's like she takes all of her blood pressure medications in the morning and at night her blood pressure is up higher or first thing in the morning. So we say, okay, Mrs. Smith, change when you take your blood pressure meds. I need you to take one in the morning and I need to take you one in the evening. And what that does, it personalized her plan, right? And it allowed for her to have better control. And you show that with the device readings. And the devices are graphs, of month over month data being sent back into the electronic health record that the provider has, or a paper chart if you wanted to go that far back and you have providers in your area that aren't using electronic health records yet. And you just fax that into the provider or drop it in electronically, depending on if you can get to their electronic health record through a cloud or web-based program. So it's really taking medication therapy management, comprehensive medication reviews, which is what the pharmacies are doing now, adding their adherence of, we're going to pack all your meds up. Now I'm going to take that conversation and say, okay, you're doing really great, Mrs. Smith. And now I'm going to add a device and say, wow, look, you really are doing great. And I'm going to send all of that back. If you had a patient on remote patient monitoring, that patient is billable at about $125 a month. So you add chronic care management 20 minutes of reviewing their data every month, and you've got yourself almost $200 worth of billable time that you just spent on that patient coming in for the med adherence calls you were already doing, adding about a 20-minute increment to it. So it's adding some time, but is it worth it for that $200 for 40 minutes of my time?
Sure.
Yeah. And the fact that that program too can be run by, but you can have your technicians, your cashiers in their downtime reviewing these informations, the pharmacists on the bench that have a few minutes, they could be looking at these devices and seeing what the patients are doing.
Yeah, that's all just about processes then.
Mm-hmm. Exactly.
And being efficient with time.
Yeah.
The devices themselves, just a real quick question that popped into my head. So does the patient pay for the devices, or does the pharmacy get reimbursed from, how do the devices get paid for?
So there's a couple of different business models out there and different platforms. One is that the owner of the device buys them. Like I could buy my devices. That's usually about $125. So it's pretty recouped, like pretty quickly. But I would be responsible for the technology support with that with that device. And so a lot of other platforms also like to do a lease program where you lease it for X amount of dollars. And within the billing codes of remote patient monitoring, I told you that the patient has to do their part, that 16 days out of the month. That allows for you to bill a budget, device budget code is what they like to term it. But it allows for half of the money to be allocated towards that device. So whether you bought the device and you wanted to do tech support, or you leased the device, and if there was a problem, the company would just send the patient out a new device and call it good, and you keep monitoring. And that lease, as long as the lease amount would be less than that budgeted code of 16 data days, I think that it's a very lucrative thing without adding a lot of support needed for these devices and really moving that forward. I think I answered your question. I kind of forgot where we were going.
No, we're just trying to see where the money comes from the device. Because
the device.
Some patients would go, no, I'm not spending $150 on the device. So being able to
it's billed through the billing codes under medical and like type B, a Medicaid. So, gotcha. Or Medicaid, or, whatever the commercial plan or ACO plan that the patient may have. So it's all billable that way. New territory is really running into continuous glucose monitor and how to pull that information into the platforms and stuff. With that, I would say that because Medicare's already paid for the continuous glucose monitor, they won't allow you to bill that budget code. So you're just down to your time. But even that is still pretty lucrative at, $60 or so for 20, 30 minutes. So it's still pretty good.
Sure. So this also popped in my mind. So these software packages, these are not part of the pharmacy management system software. This is a separate entity. Is that accurate?
Yeah, that's an accurate web-based platform that they would go to. Now, some of them are integrating with pharmacy platforms, though. It just depends on the business you pick for each, right? So, and who's talking to who. But most of them will help to integrate. And even as far as if your physician that you're, collaborating with has an electronic health record, the information may be able to streamline both ways. Go into the pharmacy platform and the physician's platform. For remote patient monitoring, that makes me a little worried because the provider's like, I'm getting all this data and I don't know what to do with it. Part of doing the service for the provider is allowing my clinical team to be able to see and manage any issues and triage any issues up the stream. Like if you had an IPI student and an API student and then you doing this program, what that could look like from triage. Yes, I saw something. Okay, let's look at this. What could our options be? Now I'm going to take it to the pharmacist and really work through that case, with the pharmacist, and then they go on to the physician with it.
Okay.
Yeah.
And again, if you also can help through this process as well, I suspect.
Yes, through the consulting and helping operate a program, for sure. That's all part of the systems that I offer in to help, who's your team that's going to be working on this? Okay, let me at them so that we can have the conversations of, what to do, what the conversation looks like, and what the stepwise process to get it done each month looks like. Okay.
So, if you're wanting to get started in this, how do you get patients to adopt remote services, because they're used to this, in-person relationship? What are some of the keys to getting them to adopt this?
So for the patients coming in the door to pick up their prescriptions, that's always a great time to have that personal conversation. But when I call the patients, because this is all done telephonically, right? These services are both done through the telephone. And when you really start diving in with the patient month over month, they know and love and come right back. But when I say that I'm a pharmacist and I have this new program and I was wondering if you would be interested, the patient's like, why is a pharmacist calling me? Like, I started my conversation at that way, and every patient was like, why is the pharmacist calling me? So I immediately say then, I know you're probably wondering why a pharmacist is calling you, but I really want to make sure that you have a personalized healthcare approach, and I want to help you get there. And your doctor loves these programs. Yeah, he does, because you're making him money and you're making him look good. Yeah,
Sure.
I work with Dr. A and they want me to do this. So now you've just built credit with this provider because he has a pharmacist on the team, and I'm the most trusted healthcare provider out there because I'm the most accessible, right?
Yeah.
So now they don't even have to go anywhere every month to get a call from me. It's an easy sell for from a patient standpoint. In my mind, as I know how I cared for patients at the retail independent pharmacy counter, same conversation usually is had.
Sure. Well, so, this, we've already covered a lot of territory here. And one of the things that I know from the point of sale world, when I start talking about all the things that we can do for you from a point of sale perspective, is people oftentimes they just look at it and go, I'm overwhelmed. I'm going to be overwhelmed. I don't have time. And then they bury their head and go, I'm not doing this. And my thing that I always talk about is that you set the timing of how this works. You know what your staff's doing, and so don't try to do everything at once. If you're not doing, actually, before I finish that thought, if they're not doing MedSync, can they still do this?
Absolutely, because they already know how to do chronic or MTMs and comprehensive medication reviews, and you're adding two pieces to a comprehensive medication review or an MTM, and that's the clinical outreach and patient information. Like, you're allowing the patient to make notes on that care plan. And so they already know how to do that. Their interns are doing those for them. So same. Yeah, they don't have to do this if they're not med syncing. But it adds nicely to the conversations that med sync pharmacies are already making.
And that was what I was going to say, is that, I suspected they didn't have to do it, but it just, I think it probably makes things more efficient when not.
Yeah, and if you're doing a MedSync program, you're not going to just MedSync month after month, year over year for the patient without asking, are there any changes? Because if not, you're going to have to redo it. And no one wants to spend that time. So take a minute to call the patient and get it streamlined, but you're already taking that time to call the patient, or your team is, and then what you could do from there.
Sure. Well, so that takes me back to where I was going, is don't try to do everything at once.
Mm-hmm.
Start small and one step at a time, and don't, because that is overwhelming. If a person, listening to this conversation right now, said, okay, I'm going to do it all, they're going to overwhelm themselves and their staff, and it's going to fail. I mean, that's my experience in the POS world. Yeah. So we're going to do everything from day one. Well, no, you're not. It's not that. That is absolutely going to ensure failure.
Yeah. My starting point for most people is take a provider that you know and knows you and likes you and trusts you already, and take 10 patients, take 20 of their patients and trial this out. 20 of their patients that you already have MedSync on, so you're not doing anything extra. Start with chronic care management and look and see and feel that out. The steps for chronic care management are the same steps for remote patient monitoring from what's clinically needed. So once you learn that system, it's a mimic, but you're getting more because you're doing more with that patient with the remote monitoring piece of the device. I did want to make one quick stop about the devices. I get a lot of questions about, does it have to be Bluetooth? Does the patient have to set it up? Could it be wireless? I recommend wireless so that there's no problem and no setup for the patient, because we are dealing a lot with the Medicare patients that can barely change the batteries in their remotes. So we need to think about that when we look at devices. But I love the technology behind this. And I think that if you mimicked a small group of one of those providers that you're already really close with, I think you could pull them in quickly, see the value, even at 20 patients. I mean, you're going to feel that, $1,500, $1,600 a month revenue for not dispensing a thing or having to sell a thing month over month. And I mean, that in and of itself is that reoccurring revenue piece is worth a look at this, if nothing else.
Absolutely. And I love, starting small. because that's, and you get to test it and you get to work out the kinks before you roll out. And then once you gain, so I think the other thing that happens is you gain confidence, right? Your staff gains confidence. We've talked about drug-induced nutrient depletion recommendations. That actually was a conversation in the last, when you were on previously. And the tip that I've heard on that is, pick one drug, a statin, and learn everything you can learn about CoQ10. Right. Teach your staff everything they can learn about CoQ10, and only recommend CoQ10. Don't worry about anything else. And once you become really, your staff, you are really good at how to do this, then you add another, you add something else. And I teach the same thing with point of sale when you're going to go on inventory control. Don't go on inventory control with your entire store. Do a small vendor that you buy 50 SKUs from. Right. And test it and do it over and over and make sure that, I've got this down. My staff knows how to receive. My staff knows how to order. My staff knows how to count. Everything is working. We're selling it. It's in the system. And you go, okay, and you're running these perpetual inventory model for months. And then you go, okay, we've got this down. We've got the process down. This is going to work. And then you roll it out again, not to the entire store. Right. And I think that's, these approaches of building processes that you can repeat. And that's one of the things they talk about in the Myth Revisited. Stop baking the pies, but create a process that the pie is going to be perfect every time. And that's exactly what you're talking about here. Yeah. Well, let's, do you have anything to add? Anything else that we haven't talked about that you wanted to chat about?
I think that the biggest thing that I keep seeing as hurdles is keeping our mind here around dispensing and around PBMs and around, not being provider status and not being all of these things where it used to be, but no one's looking out here for other solutions. And I think if we look at our processes already that we're already doing and already having and have the team already doing, how do we then monetize that? Because that's where pharmacy has not ever gone, is based around our time. And I think that whether it's this program or some other program, clinical program or not, point of care testing or PGX or, any of it, you can pick your poison of what you want to do, but you've got to start thinking about how it's going to affect your time and how you're going to get paid for your time, because those things, as the only healthcare worker that doesn't get paid for their time, this seems crazy to me. We've got to really reverse this switch and really try to open the windows up of getting behind our blinders, taking them off, and really looking at what more can I do instead of dispensing, because we know that may come or go. It's going to get better. We feel that it's going to get better, but how do we get there and stay afloat while we get there? And I think that there's a lot of work that is already being done in pharmacies today that are just not being appreciated, from a overall healthcare umbrella of all of the things that we really do. We've got the focus on us because we've carried the nation for the last 2 years on, testing and vaccinations and all of those things. But that's going to start going away. And so where else can we show our value? And I think this is a great next step to drive into helping them, allowing us be the healthcare experts in medication and just move.
Absolutely. Well, and, I'll add, because I just want to remind everybody of this, you just added a whole bunch of patients to your profile by doing vaccinations, people that have never been in your pharmacy before, and maybe they haven't transferred prescriptions or anything at this point, but you have had an interaction or multiple interactions. Right. And this is the time to focus on how do I continue to have interactions with these people? Right. How do I make these into lifetime customers? And so don't put the blinders on. Right.
Exactly. Use that list of all of those vaccinated. You have their email, you talk to them, or you have their phone number. Did anyone call them and say, did you know we have these 10 amazing services? Does your big box store do that? Because I don't think they do. Right. And then sell it. Has there been outreach?
Right. That's the key here, is outreach. You have this new list, And so definitely outreach is huge, and to take advantage of what has been a great opportunity. So, well, yeah, I really appreciate you coming back.
Yes.
This has been a great pleasure, and I hope that all of you in the audience have, learned a lot from this. I know it's a lot to take in, right? It always is. We don't use around here at RMS. We don't use the word change. We use the word improvement. We're always trying to improve.
Right.
I mean, sometimes that requires change, but we don't use that word because people
Right.
take that word negatively. So
that's hard. That's hard.
Right.
Change is hard. We don't want hard.
That's right. We're just going to improve, continue to improve. And
evolve into more clinical space so that we can get paid for our time because we are valuable.
Absolutely. And that is a mindset. Absolutely a mindset. So, well, thanks again. Look forward to having you back again down the road. Where am I going to see you next?
So right now I'm looking at trying to get PPA, Pennsylvania Pharmacists Association is coming up with the mid-year in February. I'm going to try to reach out to them and speak again on that behalf of extending your clinical services in an independent kind of way. And, I'm doing a lot with RPH Ally as well, a new platform, getting on with them and doing some channel updates with them on some of these services. So you can find me there. You can also find me on LinkedIn or even on my website, tmrx.care.
Great. Well, thanks again, Tia, and you have a terrific afternoon.
Thanks, Fred. You too.
Okay. Bye-bye.
Thank you. Bye-bye.